Yep.
Okay. Well, thank you all for joining us. We are super excited to be sponsoring this webinar through the American Society of Geriatric Otolaryngology on how old is too old for treating head and neck cancer. And to dive in a little bit more into the care of older patients with head and neck cancer. It's a passion of all of us that are on this panel, as I know many of you as well. So we appreciate you taking some time to join us. I'm going to just jump in here. I'll introduce our panel in just a moment, but just a little bit of background. As I was preparing for this, I found some interesting facts I wanted to share. So, what is old? And I was fascinated to find that the National Institute of Health and the National Institute of Aging have actually defined 3 different classifications of old. There's the young old from 65 to 74, the older old from 75 to 84, and the oldest old, 85 plus. And I think that at least in my practice, as a head and neck surgeon here at Washington University, is that oldest old that are often kind of the most challenging and frail. As we all know, there's a big difference between this chronologic age and the physiologic age. I like to say, 70 is the new 60. I think a lot of patients are in better and better shape. But then also we have some 60-year-olds that almost seem like they're 80 physiologic. And so we're going to delve in a little bit more in terms of how we can assess these patients. Now, just some statistics. As you know, the population, the older population is growing tremendously. So from 2019, it was estimated in the U.S. there were 6.6 million patients or individuals in that oldest old group, 85 plus. And that's projected to double, actually about 118% by 2040 to 14.4 million. So the older population, especially the oldest old, is only going to be increasing. And upwards of 25 to 40% of all head and neck cancer patients are in this older population, at least over 70. So it's a real, it's a real live issue that we deal with. There's a lot of patients and even more patients that are going to be needing head and neck cancer care. And so this is an important discussion that we have. And there's a number of challenges in head and neck cancer treatment in the older population. And just to name a few, as we know, there's reduced physiologic reserve or frailty. Oftentimes older age is accompanied by frequent comorbidities. There's also the treatment toxicities. As you know, head and neck cancer treatment, the surgery, the radiation, the chemotherapy is quite intense. And so I think if you look at almost any body site, cancer site, head and neck has got to rank on the highest in terms of the intensity that cancer treatment pressures that patient. And so this is even harder in the older patients. And then also, a lot of older patients have not been included in the clinical trials that guide our treatment recommendations. And so there can be some gray areas in terms of what's applicable, what's beneficial, and what's not in this population. And at least I can say at our institution, I think probably at most institutions, there's a huge deficit of resources to assess and also support geriatric patients. And so hopefully this is something that is growing, at least in my institution and elsewhere in all of our institutions. So today, we've got an amazing panel. I'm going to introduce them in the next slide. And we're taking this as a kind of a multidisciplinary tumor board setting. We're going to be presenting three cases of older patients. And the objectives are first recognizing and avoiding ageism bias, the treatment options in the older population, how to optimize these treatment options, and then also how to have that challenging advanced care planning or hospice discussion with patients. So without further ado, As I mentioned, my name is Jason Rich. I'm a head and neck oncologic surgeon at Washington University in St. Louis. Not the Washingtons on either side of the coast, just right there in the middle of the United States. And we've got a wonderful multidisciplinary panel here. So going in alphabetical order, we have Dr. Lannis Hall, who is also at Washington University. She's one of our seasoned radiation oncologists. She and I have been working for many years together. So it's just great to have Lannis. We have Scharukh Jalisi, who is the department chair of Otolaryngology at Beth Israel Deaconess Medical Center with the Harvard Medical School. And we're so glad to have him. He's also on the ASGO executive board. Helga Coleman is also at Washington University. She's one of our, I call her our ENT anesthesiologist here at WashU. She helps us with all of our challenging head and neck cancer patients and difficult airways. And we've been working with her for many, many years. We're really excited to have Kathleen Lee, who's also at Beth Israel Deaconess Medical Center at Harvard. And her specialty is hospice and palliative medicine. And we're so excited to have your unique perspectives and skill set, Kathleen. And then Tanya Wilds. And Tanya and I go back way long. She used to be at Washington University as well, and now she's at the University of Nebraska. And Tanya has a passion clinically and with research in caring for the geriatric population. She's a bona fide geriatric medical oncologist. And so it's so good to have you on our panel too, Tanya. So thank you. And a big thanks to Alexander Churn at Johns Hopkins, who is curating and hosting this webinar. So again, what we're going to be doing is maybe not as much the nitty-gritty in terms of what suture is going to be used in a particular procedure, but kind of more of a 30,000-foot view as we talk about patients. I'd like to get all of your input as we go through this from the different disciplines of how you assess patients, what are you thinking, what things are you modifying, how do you approach this older population with head and neck cancer. So I think to start off, I'm just going to throw this out to our panelists. What is ageism bias, especially in head and neck cancer, and how can we avoid it? So I'll just open that up to our group. Any thoughts on that?
Yeah, I can start, Jason. So I think this is, and thank you for the ASGO to allow us to present this really important topic and growing importance of need for continued treatment in head and neck cancer for the elderly patient. So I think it's a long held fact that, you know, as a patient gets older, we cannot provide them with standard of care. But as you mentioned earlier, you know, with frailty and so on and so forth, I think the chronological age and the actual biological age, we're seeing a divergence in that. So I think there are still certain things that in our institution, patients do not get offered based on the age, like cisplatinum, and it'll be great to hear from Dr. Wilds what's the current standard now. You know, sometimes the older patient today, I saw a patient who's 92 or something with my fellow, I think Laurent Gendry is online, and we're talking about, should we take off a cancer on the top of his head? You know, he's got multiple comorbidities. So I think to avoid it is to have a multidisciplinary discussion. So I'll let other folks talk about it, but I think that's the way forward for these patients.
Thank you. Thank you very much. Any other thoughts on that?
I agree, but I would say I think we're improving. I remember just 10, 15 years ago, if someone was in our clinic for a new consult, if they were 80, automatically, I know I was thinking about, I can't give 7 weeks of treatment, and the medical oncologist just even refused to consider systemic therapy. And I think now in the last decade, we're at least trying to have an objective measurement of whether a patient would tolerate therapy, whether they're fit for it. And it's good that we have some basic tools, but quite frankly, ASGO, our society, has not really developed some rigorous assessments for patients who are elderly and patients who might have some of the common comorbidities that go with being an elderly patient with a head and neck cancer, like dementia or early onset dementia. We really do need to have these discussions, and I'm so happy that you are convening this, Jason, because it's important. We're seeing it once a week, so we need to talk about it.
Absolutely. No, thank you. You know, it's kind of like threading a needle. You know, we don't want to hurt anybody, but at the same time, I think, you know, as a surgeon, I've seen many people that can have a very simple outpatient, you know, local or IV sedation procedure of a, you know, like even a skin cancer that other people have thought was incurable, and they can be treated and go home the same day, but sometimes that's not offered, and then you have local tumor progression. And so it's this balance, and it's this discussion I think we have to have in all of our disciplines. Well, I'm gonna jump into our first case, and let's see here. There we are. So case 1. So this is an 81-year-old male with a new onset of dysphagia and dyspnea on exertion. Now, what's interesting is about a year and a half, he underwent narrow field radiation for a T1N0 laryngeal squamous cell carcinoma. And so this was done at outside institutions, so we don't have all of the records in terms of the fields, but from what we understand, it was narrow field to the larynx. Also had prostate cancer treatment with radiation 5 years ago, otherwise fairly healthy and active. On imaging, you can see the CT scan and PET scan on the right side here. The patient has a right central neck mass that's invading both into the trachea and esophagus, causing the dysphagia and the dyspnea. No distant metastasis. So and biopsy showed this is a squamous cell carcinoma. So we are assuming that this is probably a central neck or paratracheal recurrence. And so this has grown and is now quite symptomatic for this patient. So, you know, I'm going to kind of just start off to frame things. You know, when I talk with patients, I usually will, especially older patients, I usually will frame things in definitive, curative, and palliative, so we can kind of have that discussion. And so, to kind of get us started, I'm going to just put out there what you know, after a discussion, these were the options that were put out. So surgery would entail a total laryngectomy, a fairly extensive tracheal resection going down quite low, esophagectomy, and probably a free tissue transfer. And then radiation would need to be afterward, you know, radiation afterwards. Or, you know, potentially definitive radiation would be re-irradiation, probably needing protons, but again, with probably even a lower chance of cure with radiation alone. And then also palliative. And so, you know, what I would like to start out with is, we're talking about some pretty radical treatment. So I'd like to first of all, send this to our radiation oncologist, medical oncologist, and surgical oncologist. How do you assess a patient, an older patient, for their eligibility to undergo the care that you would provide, whether it's radiation, systemic therapy, or a surgery like this? What do you have any mechanisms? Is it a gestalt? How do you assess these patients?
Well, Jason, it used to be that we did the eyeball, the look over to, you know, to see, you know, did they look like they were in a reasonable weight, and did they drive alone, or did they come with someone? Do they have social support? Were they able to communicate their side effects and the history properly? How many medications were they on? And this was just overall nothing formal, but now we have these comprehensive geriatric assessments that truly can help us determine if someone's fit or unfit. And those took too long, to be quite honest. So now we have incorporated our social worker to help us better understand the needs of our patient. Are they food insecure? What will transportation look like? Do they have family support? Can we mobilize the family? Does it look like they can tolerate a mask? And do they have other comorbidities? This is a difficult situation, this particular case, because this is a reirradiation with probable overlap with the prior field. So then we're talking about some serious complications of fistula and possible brachial plexopathy. So that's just a whole nother discussion. And does that person have the insight to understand what we're saying as the potential complications of reirradiation? But I would say to summarize and crystallize what we do, it is now incorporating a social worker in a formal consultation and letting her know that we would be offering 5 or 6 weeks of radiation, and what does she foresee as the needs of this patient after doing her assessment. And we have armed her with the NCCN distress score that we now use on a weekly basis with these elderly patients. But then in addition to that, she has her own expertise because that's what she's trained to do in the cancer center. So I would say we're not quite there yet, because there's a broader assessment we can do, but we try to get it right in terms of whether we think someone we should not even consider a definitive aggressive reirradiation program versus something more palliative.
That's wonderful, Lannis. Have you found that, I wish we were all doing that with the social worker. Have you found that the social worker's input has kind of made or break or really changed a treatment plan in your practice?
It has, and this is where it's come in. Our social workers found out that some patients truly were food insecure, that they did not have enough resources to help them with their dietary needs. So then we could support them, but then we found they didn't have enough finances for transportation each day. And then we found that we didn't have a reliable relative to help them get here. So when you start counting up all of those issues, they don't have reliable transportation, no social support, they're food insecure, they're barely making enough in their Medicare and other resources to cover their monthly expenses, and they're living alone. I felt that by the time we talked about 7 weeks of treatment, that we were going to push those people over. So then we really started to have a conversation with them about what it would entail and what it may mean in terms of acute and subacute toxicity. And a lot of the patients said, well, I really didn't understand it was, I might have a really sore throat and, these other issues. So then we talk about a G-tube. And that's when the social worker says, I talk with them again in plain terms, not the terms sometimes that we use, and not occasionally how positive we can be about the therapies we give. But on a realistic level, the social worker is very helpful in saying, I just don't even see how this is going to happen. And we then go back and reconvene. Can I tell you, the social work has been great in mobilizing other family members to really get engaged by calling them. And it was something that I just didn't do.
Yeah.
I didn't do that. I just didn't start calling people.
Well, I love the focus on, the fixed income that a lot of patients are on. And I know that in my practice, I just recently have a patient who was so reluctant to call any of his children for help because he didn't want to be a burden, that it's a real issue.
Yeah.
Tanya, can you comment? Dr. Wiles has done a lot of research in the assessment, and so I'd love to get your thoughts in terms of how do you assess these patients?
Sure. So there's actually a wonderful body of literature in the medical oncology world. I think when we're looking just at the chemotherapy side, it makes it really easy to be able to do shared decision making and lay out for the patient what their risk of toxicity is with systemic therapy. Unfortunately, all of the geriatric world is pretty siloed, and so to my knowledge, there's no studies doing the same type of assessment of increased risk of toxicity in multimodality type treatments. So in the systemic therapy world, there was a chemotherapy risk prediction tool developed by Dr. Arthi Huria, published in the Journal of Clinical Oncology in 2011, that remains kind of a very valuable tool for estimating the risk of chemotherapy toxicity. And basically by using 5 demographic variables, including age over 73, with tumor type, in this case, patients wouldn't get points for that. GI and GU cancers tended to have greater toxicity if you chose combination chemotherapy rather than single agent, hemoglobin, and then 5 geriatric assessment parameters that included was the patient able to walk a block? How was their hearing? Had they had any falls? And a couple more, sorry, not off the top of my head. But basically, you could then stratify the patients into low, medium, and high risk and estimate for them what their risk of grade 3 or 4, basically serious enough toxicity that they might require hospitalization or kind of serious or life-threatening complications. And this completely outperformed just using ECOG performance status. And then further, with incorporating principles of geriatric assessment into the care of older patients receiving systemic therapy, probably 4 or 5 and counting randomized trials have now demonstrated that doing a geriatric assessment prior to initiation of systemic therapy can actually reduce the risks of severe toxicity of chemotherapy by varying by studies 10 or 20%. And these geriatric assessment studies have varied from the patient just basically filling out questionnaires and giving it to the medical oncologist, along with some possible suggestions for what geriatric assessment vulnerabilities might prompt. One example would be polypharmacy may prompt conversation with a pharmacist, or a history of falls may prompt referral for physical therapy. So there's a number of things we can do to assess the patient's likelihood of tolerating chemotherapy well, and then to intervene to try and reduce that risk of toxicity.
Now, would you say that it's improved the toxicity because practitioners have looked at that and decreased the treatment, or they've just been aware and been able to preempt some of the potential problems?
Yeah, great question. One of the studies did demonstrate that the practitioners were more likely to do primary dose reductions when they were identified these vulnerabilities. And the good news, though, is that did not compromise their cancer care. There was no difference in overall survival, whether the patients received standard dose therapy or primary dose reductions based on the geriatric assessment. In some of the other studies, it really was a combination probably of the dose reductions as well as the interventions. But they're still kind of disentangling that because it is a complex intervention to do the geriatric assessment and then the referrals that followed from it.
So Tanya, maybe just kind of get a little specific on this patient then.
Yeah.
So I know we don't have all that information here for you to do that assessment, but for this particular patient, say this patient decides to go with definitive radiation. We know that he would do better adding chemotherapy. How comfortable would you feel adding chemotherapy to him, and kind of what would be, if you decided not to, what would be the reasons why, and what kind of what's going through your mind, what potential complications, how do you think about that for this particular patient?
Yeah, I'll have to put the asterisks on here. I have moved away from head and neck. It's been 5-6 years, and I've moved into a different disease-focused area. So if there's been any awesome advances that I've just missed, I apologize. But yeah, pretty much the same. So, in an 81-year-old, we already know that just as a natural part of the aging process, his renal function will have been declining. And we know that the best data is for the use of concomitant cisplatin. And so I think I would already be having some reservations there and wanting to calculate his creatinine clearance. And then I'd be taking into account his tolerance for the potential nausea, vomiting, anorexia, dysgeusia, and the nutritional hit that he might be taking here. As Dr. Hall mentioned, just the need for intensive supportive care. What is his social support circle looking like? So I mean, just off the cut, trying not to be ageist and just looking at his age alone, I can tell you just based on this, I would have some hesitation about using a cisplatin-based approach. And the role for carboplatin versus cetuximab as the adjuvant, I think that at least as last I reviewed it, it seemed like there wasn't a clear winner, and there were certainly reasons to consider whether we were getting as much benefit as we would like to be getting in that setting. And I think one of the things I find the most freeing that I've discovered in geriatric oncology is that shared decision making and really taking into account the patient's preferences allow us to relieve that feeling of burden that we need to pick the best treatment for this patient, because there is going to be a range of patients' tolerance for toxicity, meaning what they're willing to go through and how they balance out their quality versus quantity of life. In the geri-onc literature, study after study has demonstrated that older patients prioritize maintaining their independence and their quality of life over overall survival. This isn't just a gestalt that we've all picked up, data supports it. And so kind of, Jason, it's really interesting that you laid it out here. I lay it out for the patients as curative versus palliative. And that's absolutely one approach that's perfect, to lay out for them their options and then and then seek out their preferences. Another option is to try and help them verbalize their preferences and then lay out their options in the context of how those may meet or may fail to meet their preferences. That can be a little bit hard. Most people often haven't thought of what their preferences are, and it's not something they can really put in words. We often more read it from their face as you're laying out for them what a pathway might look like, and you can just tell they're saying that's not going to be the pathway for me.
Right.
Thank you. And I want to get back to the shared decision making at some point in this webinar. So thank you for bringing that up. Scharukh, so you've got this patient here. I'd like to hear, how do you assess a patient for, whether they can handle a surgery, especially something big like this, and what your thoughts would be in this particular patient?
So I'll echo what's already been said by Dr. Hall and Dr. Wiles. I think the important thing is, what is their functional status? But more importantly, what we focus on is a few other things, which is what kind of support do they have? And the most important thing Dr. Wiles just talked about is what is important to the patient? Where do they want to be? I mean, having this surgery, and if a person only desire to live is to talk and go from there, then that's a problem. It's not compatible with their expectations of life. And as I say, if it's not worth living, it's probably not worth doing. So that's what we look at. But from a more, let's say we pass that point, then really need to look at the functional status, their heart, their lungs. We do have a multidisciplinary team that's evaluating these patients. If someone's got heart issues, they're going to get a nuclear stress and so on and so forth. Ultimately, as I have learned over time, that you will not eliminate comorbidities or make them better, but hopefully we can get them to the best they are, optimize them to the best they can if they want to have all this done. But I think patient consent and them understanding what is it that we're about to do, and if it is compatible with their desires, is important. We do engage our palliative team, so it'd be great to hear from Dr. Lee what she does with these patients that come over, because we do engage them, because they provide us guidance, and they help with the patient guidance and decision making. So I'll stop over there. I think there's a lot of these things that we've talked about, which is similar for, I think, med-onc, rad-onc, and surg-onc. In addition to, does a patient really want to do all this? The other thing is we do see patients coming from far away. So one of the other things we have to think about is, what are the local resources available? For example, if someone has a laryngectomy and I'm not going to do a TEP on them, if they live in, Podunk, New York, or someplace where there's no support, and I know they're going to leak in 3 months and no one to change it, we'll go for the electrolarynx. So I think looking at the resources available to the patient in the local community is very important as well. So those are things we think about as we go around taking care of these patients. So it'd be nice to hear from Dr. Lee what she thinks about this.
Absolutely. Thank you, Scharukh. I think there's a couple points I just want to emphasize. You've all three mentioned that as education. And I think that sometimes for older patients, it's whether it's hearing loss or maybe some cognitive challenges, it's sometimes hard for them to fully hear and grasp. And so I found it's very important to get the family engaged early on. I think it is critical. In fact, when I see a patient that's in the older group without family, I schedule return appointments saying, look, we need to have this discussion so that we're all on board. Not just the patient who says, yeah, I want to do this. You know, I found we need the whole family together. And I think one of the unique things about surgery is I like to tell my patients, you know, your function can slowly decline, or we could do surgery and it'll acutely decline and it may not come back. And so I think that's the patients oftentimes find that very helpful when they're focused on quality of life. It's like, well, you know, heck, if I can go play golf for a few more months rather than be stuck in a hospital having postoperative complications, I think I'm going to go with the other ones. I can keep playing golf. So, well, good. So with that, let's bridge into Kathleen, and then after that, Helga, I'm going to ask you about kind of the anesthesia concerns. So Kathleen, let's say that, you know, I think it's hard for many of us who are so intent on curing patients, we almost see it as a defeat to have to say, look, we're not going to try to cure this. And I think that many of us, and I would say I've probably gotten better, you know, as I've progressed in my practice, but a lot of us don't know how to have that discussion. And so I'd love to kind of see how you engage with patients and their family when you engage, and how you kind of approach this.
Sure. Yeah. You know, sometimes I will sort of, particularly for our fellows and our learners, I sort of share, you know, that as palliative care specialists, you know, I think we sort of hone our skills to have these difficult conversations in family meetings, similar to, you know, operations and procedures. I think what's different sort of between surgery is that I think there are certain tools that we have in our toolbox that all providers can use, you know, and I think relating back to this case of this 81-year-old who has already had, you know, radiation, I think, as all of you have been saying, Dr. Jalisi, Dr. Holland, Dr. Wilds, it's really important to take a person-centered approach of these conversations. Making sure we're optimizing the environment, as you said, Dr. Rich, you know, quite astutely, given they're older, do they have hearing loss? Do they have cognitive decline? Really, who supports them, you know, to help make decisions and get information if they're not following or processing everything? So making sure we're having everybody that we need to have a very informed conversation, I think, number one. And then I think number two, once we sort of have that optimal environment, making sure they have their hearing aids, you know, and their essential family members to help keep notes, getting a sense, you know, specifically for this gentleman, I would sort of want to delve on number one, what was sort of that XRT prior experience like? You know, was it tolerant? Was it sort of no big deal? Was it pretty traumatic, you know, sort of sitting for the radiation? What was his quality of life and his side effect profile during and after treatment? And sort of what was his quality of life and his functional status sort of after, you know, within this interim period till he developed the onset of dysphagia and this new recurrence. And then I think, you know, I think as many of you do, you know, I think in my practice, if I get a referral from Dr. Jalisi or a colleague, just like, what have you last heard from your doctors? Just to get a sense of what their current illness understanding is and prognostic understanding. What did they hear, right? Because as you were all saying, we have these conversations. We think we're really, really clear. Maybe they just heard cancer's back again and they didn't hear anything else. And we did hear say it, but they just didn't integrate it in their takeaway. So it's really helpful to know where you need to sort of leave off, or do you need to start all the way from scratch? You know, and I think as Dr. Wilds was saying, I think the other thing, sort of before getting into sort of what all the treatment options are, something I often will try to aim to do is how do they want to provide their information, right? To sort of guide you on how best to inform them, how much best. Some people like all the details. Are they the people that want to get all the nitty gritty, or are they people that just want the bottom line? Or are they other people that just, hey, they have some mild cognitive impairment and they just want to defer to their family members? So at least you have a sense and a context of, okay, this is how I'm supposed to proceed when I am sort of delivering and having these conversations that are complex about definitive curative therapy versus palliative and what makes most sense for them. And I think honoring those information preferences then also gives you more information of how you need to share the news and move forward. Sometimes this is a stepwise process, and you can't sort of have everything settled in one time. So, as you were saying, Dr. Rich, it's like if someone is super emotional or angry, oftentimes we'll just say, hey, so it sounds like this is a lot. We discuss X, Y, and Z. How about we come back, next week? Or in the inpatient setting, let's come back in a couple of days after you had time to process it, because clearly, the informed shared decision-making process really can't happen if people are in a high emotional state. And I think once the emotions are sort of out and you have a sense of people's information preferences, oftentimes I will just, it sort of depends. If some people want all the details first, there's some frameworks we use, and I'll sort of put them in the chat. So sometimes I'll just get a sense of, given everything's going on, if I have a better sense, they have an understanding of where prognosis is. Sometimes it's just me having to deliver that news, have that land. And once they're able to process that and sort of really hear where they are and what the options are, get a sense of what's most important to you, what makes most sense. And then, as Dr. Wild said, ideally having the values and their priorities and their trade-offs and their worries really guide which of those treatment options make the most sense. And so you can then make a really curated recommendation based on those goals and values, as opposed to, I think, sometimes giving them that sort of laundry list of, or the Chinese takeout menu, I've heard some people say, and it can be incredibly overwhelming, where they're feeling like they have to make the decision, where it's actually, we're the medical professionals, they know themselves best and what's important, and we need to work together to figure that out. So that's a little bit in a nutshell. A couple of frameworks I use, particularly in surgery and also in these gray areas where I think we are falling into a lot more, where it's not really clear cut. We don't have great data to see which way is better than the other. Gretchen Schwartzy out of the University of Wisconsin is a trauma surgeon that has done a lot of great work on using a communication skills framework that is, I think, has gotten a lot of headway with surgeons specifically, and sort of using actually best case, worst case. And some of you may use this already. So actually drawing a diagram of, okay, so if we're doing definitive therapy, best case, X, Y, and Z is going to happen. Worst case, we do XRT, as Dr. Hall said, we get a fistula, we have to manage that. This happens, you end up in the ICU, recurrent infections, you may die in the ICU. And then you say in the middle, and you put the star there, this is sort of where I think you would most likely lie. So then it's very concrete to them about where you see them possibly going in a matter of sort of uncertainty. And then sort of do the same thing with palliative therapy. And then if, they're sort of saying, hey, I just want to focus on my comfort and quality of life, you can kind of also get a sense of what comfort focused care would look like. And so I think that is a really nice framework. And then there are a couple of other frameworks that I'll put in that Ariadne Labs here at Harvard, the Serious Illness Conversation Guide, and Vital Talk, which is a nonprofit that sort of aims to improve serious illness communication, sort of really gives those tools to providers on the front line, not just palliative care specialists. So I'll put those in the chat right now.
That's wonderful, Kathleen. Thank you. I think that's something I hadn't heard about that framework, but I think it's wonderful. We'll include all of these links, on the webpage so that people can come back at that, because these are great resources. I wish we almost had an embedded relationship with hospice and palliative care physicians in our clinic, because I think even if patients are going for definitive care, there's a lot of support that can happen, getting involved earlier with hospice and palliative care physicians. And I was always struck with, there's a study, you could probably quote it better than me, but that actually when hospice was initiated earlier on, patients actually lived longer, and with better care than not. So I appreciate you sharing that.
Yeah. Yeah, and that was the Temmel study in New England Journal of Medicine in 10. It was the first RCT in the palliative care field where people with metastatic small cell lung cancer got standard chemo, and then or got standard chemo and palliative care. And I think to your point, I think there's some data, but I think it's limited, that I think longitudinal palliative care is really where I think we can make the most impact to sort of follow people throughout their cancer journey.
I agree. Thank you. Well, so I want to now kind of move to the operating theater. So I oftentimes call Helga my enabler because she enables me to do all these surgeries that otherwise I think many anesthesiologists would say, no, there's no way we're not going to do this. I have a advanced skin practice. The majority of what I do is advanced skin. So oftentimes we have 80 and 90-year-old patients that we're doing surgeries on. And so Helga and her colleagues are often quite helpful in helping us get patients through this. And I know that there's post-operative, it's a whole other discussion. We probably don't have time for that, but Helga, I would love to get your thoughts when you see, so let's take a huge surgery like this. Okay. So, we'll just, total laryngectomy, free flat patient, an all-day surgery, and you see somebody that's in their 80s, what's running through your head? Other than, I can't believe the surgeon brought me this patient, but but okay, we're here now. What things do you think about? What things do you do intraoperatively to kind of make that a safe procedure?
Yeah, thank you, Jason. So I would just a little bit give you a framework for what we do. It's not only intra-op, it's also pre-op, and it's also early post-op period, right? And that sets you to success. Mm-hmm. So in pre-op period, when patient comes to the pre-op assessment anesthesia clinic, it's really important, a thorough assessment of the patient, distinguishing all, the highest risk factors. But the most importantly, it's prehabilitation of the patient, because this type of the patient, 81-year-old, laryngeal cancer, probably has some type of malnutrition, probably former smoker. So this patient has a nutritional status that is not favorable for the success. Also, given the age, we also want to do possibly some cognitive rehabilitation and then physical. That's in ideal scenario, right? We also want to test this patient. We want to do a mini cog. It's a very simple, very short test where we are testing this patient for dementia, because if we show that this patient has dementia, most probably in a large number of cases, the patient may have post-op cognitive dysfunction further. So again, prehabilitation of this patient for me will be very, very important, which obviously presumes that once you saw the patient, once you all agreed that this patient is going to have this big surgery, when the patient comes to the anesthesia clinic, that has to be on time before surgery, let's say at least 2 weeks, so we can optimize as much as possible this patient, again, from the nutritional standpoint, hopefully physical and cognitive standpoint. When the patient comes to the holding area, obviously I know everything about the patient. I went through the chart. We created a plan for anesthesia for this patient. My main 2 goals are obviously to keep this patient stable, but not only hemodynamically stable, it's to optimize DO2, so delivery of oxygen in tissues. And 2 main goals, it's the patient's brain and the patient's free flap. Because if the perfusion of the flap is optimal, if I'm not overloading the patient, if we have optimal level of hematocrit, the cardiac output, mean pressure, everything, if that's optimal, I'm setting you for success. And then also, I really, really want to avoid post-op cognitive dysfunction. Why? Because this gives a lot of problems in the post-op period, not the first day, but in first few days and even further on.
Mhm.
So these are my main goals intra-op. When patient comes to the recovery room, we want to make sure, again, that we have hemodynamically stable patient in optimal fluid status. We want to see, hopefully, that patient is not delirant, doesn't have any kind of early post-operative cognitive dysfunction, because let's not forget that patients are having all sorts of cognitive dysfunctions post-operatively, up to 60% of them. And it can be not only delirium, but it can be all kind of them. And again, let's not forget that delirium may be also silent. So it's hypoactive delirium. So we think our patient is doing well, but actually not. So when we have hyperactive delirium, it's obvious. When we have hypoactive delirium, we have to be aware of that. We have to notice that, because then we can also be proactive in how, as soon as possible, get out of it. And that will happen if we have optimal pain management, if we introduce family back to the patient as soon as possible in post-op period, if we are mobilizing the patient as soon as possible. Obviously, hemodynamics, oxygenation, the basics also, they have to be within ranges. So all these factors, in order that our patient is as soon as possible functional, independent, and to be discharged from the hospital when it was actually anticipated.
Wonderful. Thank you very much. I think there's a lot of things that I think as surgeons we're not always thinking about, but that it really helps to have anesthesia that's keyed into that. Well, thank you. I know that this was a heavy hitter. We put the biggest one up front. And I think I think you know, hit a lot of major topics. And with these next cases, we're going to kind of be doing, this is like the compound moves, and now we're going to do some small accessory muscle weightlifting here. So case 2. So this is an 84-year-old male. This is my patient. So actually he had dark jet black hair. So I think that's why this melanoma that was 14 by 14 centimeters wasn't recognized. But he came to me with this extremely largest melanoma I think I've ever seen in a patient. Past medical history, diabetes, AFib on Xarelto, hypertension. And so, he did not have any bone invasion of the calvarium, no metastatic disease. We'll go back here. So now, I just kind of set this one up as we discussed. I took care of him many years ago. As we discussed this, it was felt by our medical oncologist, and I think it was a little bit before we had a lot of. I think all we had was Yervoy at that point. Ipilimumab, which was pretty toxic, and so I think our medical oncologist said, "Look, is there any way you can remove a lot of this tumor surgically, and then we'll treat it?" And so, so 84, in my mind, this is kind of pushing the limits of what can be done. I mean, we can remove this, put a free flap on it. He's probably going to die of his melanoma, though, at some point. I mean, this is really, when it gets this big, it's incurable. What can we do to help? And so I think I'm going to start with Scharukh here. When you see somebody like this, and somebody's asking you, can you please do some type of debulking or help set this patient up so that we can give some other treatment? Are you thinking about ways to, how can you modify surgeries? Like, what are your thoughts about modifying maybe from the ideal to something a little less invasive for some of these older patients?
So interesting case, by the way, tough. I think the biggest thing, like we just talked about, was how fit are they? And what kind of length of surgery they could take. And that's where I would talk to Dr. Coleman to say, hey, what do you think? But from that perspective, and then understand the patient's goals, what they want to do. Obviously, if you're trying to go for cure, I think you mentioned it, this person looking essentially most of his scalp gone and then a free flap reconstruction. I would do a sentinel node biopsy if there's no other metastatic disease in this person. I think that would be helpful for at least the staging for our medical oncologists, which is easy to get done. But the real issue will be, he's got diabetes, he's on atrial fibrillation on Xarelto. Can he really come off his anticoagulation for a prolonged period of time? Obviously, do a free flap, we'd be worried about hematoma and bleeding and so on and so forth, the big wound. So alternatively, you can think of local flap reconstructions or skin grafts for the reconstruction part. I think that's where we would addend it. I don't think I would change my margin status. I mean, it's I don't know. I don't think you put the depth on it. Let's assume that it's more than 2 millimeters. So we do at least a
we'll say.
No, I'm sorry.
15 millimeters deep.
Yeah. So we do a 2 centimeter margin on this person,
Yeah.
and then go from there and explain to him that despite all this, given the size of this, it's very possible we may not be able to control this disease, and then discuss if that's within his goals of care. But from a surgical perspective, I still do the right margins. Probably just reduce the amount of reconstruction that's offered. Obviously, I would be worried about exposed skull, which, as it's skin grafting and all that's harder to close, but you can with many new various implants and stuff like that we have. But that's the only thing I would do. But obviously, assuming that he's physically fit and the rest of our team, which is the anesthesiologists and other folks are on board with doing all this advanced surgery on this patient.
Well, thank you. And you and I have spoken a little bit before about this patient, and I think, I want to get your thoughts on another topic. I almost consider this a palliative surgery. And so I didn't want to put him through too much morbidity. And so what I ended up doing was taking him, basically scalping his whole scalp down to bone as an outpatient procedure, put on Integra, let it granulate for about 4 weeks, 6 weeks, and then put a split thickness skin graft. So 2 outpatient surgeries, and we reconstructed his whole scalp because we weren't going to radiate. Now, you and I have been speaking, Scharukh, if you could mention, that Integra is pretty expensive. And so oftentimes we're spending a lot of money on these implants and things like that. Would love to get your thoughts, from, your experience and your healthcare center, is insurance pushing back or hospitals pushing back?
Yeah, that's a great question, Jason. So yes, these implants, I mean, it's unfortunate, but Medicare reduced physician reimbursement by 8.5% just this January 1st. I think all of us are under the stress to be more cost effective. Integra is obviously one of those products right now. Again, nothing against them, but a sheet this big on this head, at least in our institution, would cost in excess of $10,000. And with the margin contribution margin of these procedures, especially if you do outpatient, about $1,000 to $1,500, I think that's a question that you have to deal with from the finance side in the long run. That why is your group doing so many procedures that are not contributing to the margin in a positive way? So it's an unfortunate conversation we have, but again, I think all hospitals have to balance their dollars and cents. So we have to think about it in other ways, because skin grafting, you can take skin from the patient. I still like to do alloderm and all. I do stay away from Integra because of its cost for the most part. But there's other ways to do it. But yes, cost unfortunately has become a real problem going forward, especially because your contribution margin does help provide support to your group from the hospital to do many other things. Like, for example, we talked about social work, advanced practitioners, so on and so forth. I mean, that all comes from your contribution margin. And if you're a negative contribution margin department, all bets are off. And so the opportunity to help more people goes away.
I appreciate you bringing it. And I know it's something we don't always like to talk about, but it's some of the reality. And as surgeons, a lot of the downstream revenue comes from being admitted and the costs that come from that. And at the same time, with older patients, we're trying to keep them out of the hospital and minimize surgery. And so it's this, there's this tension, trying to do what's right for the patient and having other constraints. So I appreciate you bringing that up. Now, so this patient ended up getting immunotherapy. Tanya, I'd love to get your thoughts on, and I'm not sure if you're using much immunotherapy in your current practice, but I'd love to get your thoughts on, how does the older population tolerate this and its effectiveness and some of the biggest side effects? Because I know that when my patients hear, oh, I'm getting chemotherapy, they just like, I'm not here. And it takes me a while to have to explain this is a little bit different here. So I'd love to get your thoughts on this.
Yeah, when the immunotherapy first came on the scene 10 plus years ago, we were in such a black box about what to do with our older patients, because the original clinical trials, like so many of our therapeutic trials, under-enroll older patients. And so the populations that their drugs are originally tested in may be 10 years younger than the average age of the real world population. And I remember when the first time I saw a case series of people up to age 80, I'm like, okay, we start to have some data. And long story short, fast forward, a whole lot of accumulated data has demonstrated that unlike systemic conventional cytotoxic chemotherapy, there does not appear to be increased risk of adverse events with immunotherapy in older patients. And it appears that their benefit is similar to younger patients. And so we can use it a bit more with that reassurance. As far as what the toxicity profile is like, it really is primarily related on those immune-related adverse events. Which can be any range of, essentially autoimmune type phenomenon, rash, pneumonitis, GI toxicity with diarrhea, and a host of, basically anything that goes wrong with the patient, we need to think about whether it's immune mediated, endocrine disorders, and so forth. Most of those are typically dealt with using corticosteroids, but by and large, they're incredibly well tolerated. And I think one of the most well-known examples of that is President Jimmy Carter, who had metastatic melanoma and received immunotherapy, and he was still building houses at the age of, I think, 97. So just a really, really great example of how a person who is a fit, vibrant, older patient need not be denied a therapy if it's lined up with their goals. And he still was able to, be not only functional, but just contribute so amazingly. So.
Well, thank you. I this has been a godsend. I think, a lot of our older patients, I think that disproportionately skin cancer is present in a lot of our older head and neck cancer patients. We oftentimes think mucosal, but the cutaneous malignancies are actually on the rise. And luckily, as far as I understand, I think it's because of the high somatic mutational burden, these melanomas and cutaneous squamous cells seem to respond beautifully to the immune checkpoint inhibitors. And so it's great to know that there's less side effects perhaps compared to when if a younger person with maybe a more robust immune system gets these medicines, but yet they have those benefits. I know that I'm a little more keyed in just because I do a lot of skin, and many times in our tumor boards I have to say, hey, wait a second, hold on, before you do that big surgery, we have some options that we can try. And so we're hopeful that there'll be some more clinical trials, phase 3 trials, especially with cutaneous squamous cell, that can guide us a little bit more in terms of neoadjuvant immunocheckpoint inhibitors. So I think the last point I want to make on this, and we'll get to our last case, is
Jason, can I ask a question of Dr.
Please.
Wilds? I'm just curious. In some of our radiation data, our clinical trials eligibility criteria can sometimes be, so restrictive that we get the best of the best or the fittest patients that are participating in our trials. And therefore, when we do like a match pair analysis to, our SEER data set or our community data set, we find a much different outcome. I wondered in the immunotherapy space, do we see that same tolerance and lack of like significant or severe toxicity in just our population data sets like our NCDB or our SEER data set compared to what we've seen in our clinical trials?
Yeah, great question. I couldn't answer if it has been done in like the SEER Medicare type data. I just know that from the, outcomes focused, whether it was, single institution, multi-institution, real world data.
Right.
So the data I'm saying that the older patients tolerate it is not reanalysis of clinical trial participants. That's in the real world data. that they're still getting the benefit with it and not having incurring increased risk of
Yeah.
toxicity.
Right. Great. Thank
That's
you.
wonderful. That's good to hear. Thank you. Great question. Helga, a quick question on this patient, so let's say, for example, we're going to do something, a short outpatient procedure, with scalp resection and alloderm or integra on this, so about a, 1.5 hour surgery. We're hoping outpatient to minimize morbidity. Do you have any thoughts that you can share with us and all those here in terms of, as an anesthesiologist, what you would do during surgery to help make this patient just kind of bounce back quickly and not have any side effects, whether it's TIVA, IV anesthesia, inhalant, LMA versus endotracheal intubation. Like, what things are you thinking about of how can I help this patient have minimal morbidity and go home the same day?
Yeah, so relatively short surgery, 1.5 hours, which decreases probably the likelihood of having any kind of post-cognitive dysfunction, right? Because that's my biggest, problem in older patients, besides some other. I would probably say my goal will be pain management, like optimal pain management intra-op, and making sure that when patient goes home, he's well covered, because this is a huge area, right? Like, it's scalp, it's well innervated. So that's something that I would have, concerns about, and I would make sure that intra-op we cover this patient well from the pain management standpoint, and also make sure before discharge patient is doing well. Because again, the shorter the surgery, the less likelihood of any consequences, if we will, of anesthesia. We don't have possibility to use BIS, so like EEG monitoring, EEG type of monitoring, but still we would love to have, as I would say, as light as possible anesthesia, because we want to avoid any side effects of anesthesia.
Would
But
you,
again,
would you prefer IV? Oh, sorry. Would you prefer IV over inhale and like gas then?
It doesn't really make a big difference in this case.
Okay. Well, that's perfect. Thank you very much, Helga. Now the last case here, this is an 84-year-old female with a left concha cutaneous squamous cell carcinoma. So she saw a Mohs surgeon. They attempted it, but they stopped because they just found it was very infiltrative, large nerve PNI, and then was referred to otolaryngology for further management. No metastatic disease was noted. Past medical history, she has polymyalgia rheumatica on methotrexate and prednisone. So I'll just kind of jump ahead. This probably disqualifies her for immune checkpoint inhibitors, unfortunately. And also, she has dementia that's getting worse and worse. She lives in a care facility. Luckily, she has 2 supportive daughters. Now, with the ear, this is a high risk location with the large caliber nerve, greater than 0.1 millimeters. This is a T3, so this would also require ideally surgical resection to clear margins and then radiation therapy. And so what I would like to focus in on this last patient is twofold. One is, if you can't give that patient the full treatment that they require for cure, should any type of treatment be taken? Like, for example, surgery alone is not going to cure this. And so, but can she get radiation? So first of all, the ethics. Should we embark on any type of surgery if we can't get cure, or at least local control? And the second is managing older patients with dementia. And I know there's some constraints. So maybe what I'll do is I'd like to start first with Dr. Hall. radiation can be very challenging in patients with significant dementia. Can you comment on how you approach that, and is it possible to radiate, or do we need to look at different options in these patient population? You're muted.
I'm going to not just look at this patient with a Mohs procedure and no closure right right now. I just will speak to the difficulty with managing patients with dementia in the radiation oncology department. It is very difficult because head and neck patients require usually multiple weeks of treatment, as opposed to some of our other disease sites where the advances in technology have now decreased our treatments down to 2 or 3, where you can think about getting people through it no longer than 5. But this is still, 5, 6, 7 weeks of treatment typically. And for this particular case, we don't really have the option of a very hypofractionated approach, meaning giving treatment in a shortened period of time. So then that means that we would be thinking about this patient with an immobilization mask secured to the table every day for weeks at a time. And some patients with early dementia, we can voice through and coach them through the treatment, and have certain music that is soothing to them. But it is a real struggle for someone who's truly demented and doesn't know where they are in moments in time, to be down with a mask that is restricting them, along with not being able to move. That is just a very difficult situation. And this kind of patient, I would really be very hesitant in even considering any treatment. We do, as you all know, have some pleasant patients who are demented who we can get through treatment, but typically someone who doesn't know where they are from moment to moment, it's a real difficult situation to do the dark room, even with music, even with coaching, with a mask on.
This is a deal breaker for you.
Yeah, I've gotten, again, there are, as we know, different levels of dementia. We know that, right? We stage it. Early dementia, we really can get patients through, and we do frequently. This is a different situation based on what you have explained to us, Jason, and I'd be very hesitant.
I appreciate that. That's great to hear. I think that's something that as surgeons we don't always think about. Is we think about, hey, surgery, I can get this surgery done, like Dr. Coleman had mentioned, short surgery, we could get this done, but then can they get what else is needed? So I'd love to kind of bounce this to Scharukh and Kathleen now, is so should surgery even be undertaken when we know that surgery alone, she's going to have a local recurrence within a few months? Is there a role for palliative surgery? What's the ethics of this? How do we discuss this with the patient and family? And maybe Kathleen as well, you can comment on the fact that the patient's not going to understand anything we say. A lot of the decision making is going to be going with the family. So I would love to kind of get your thoughts on this.
Sure. Scharukh, would you like to go first, or?
No, go ahead, Kathleen, because I think this is something that we would handle together. So go ahead.
Yes.
Do your part. Yeah.
Yeah. So we commonly see this inpatient, sort of on inpatient consultations. I think similar to what we were saying, I think you're making sure we know who the decision makers, whether it's the designated healthcare proxy, I know there's also state dependent laws too, here in the state of Massachusetts, it gets very messy if people don't have a designated healthcare proxy. It can be, so we don't have sort of surrogate decision making that, okay, it's the significant other and you have to go get a guardian, and Scharukh knows it's very, very painful. So I think first and foremost, making sure you have the right people in the room making decisions on behalf of someone with severe dementia. And I think pre-meeting, having a meeting like we're having right now to sort of talk really sort of expert to expert, sharing each other's expert perspectives. So we were all on the same page and learning more about the complexities from each of our expertise, and then getting a sense between us, okay, what makes sense for us to deliver, sort of what is our headline going to be, so to speak, to this family. Whether it's, I worry that radiation is going to be really hard to tolerate. And if we're looking at resection, even using some of the framework I mentioned, best case scenario, this is what we're looking at, see where that lands and see how they're processing. And then based on where she is and the limited treatments, what's most important, what are you guys leaning toward? And then making sure we're filling in the blanks and answering their questions. So we're really, sort of having a shared decision-making process that's effective, and at the end of the day, doing what's right for the person. Sometimes, I think Dr. Wild had said this a little earlier, right? It's really hard. I think advanced care directives, advanced care planning is wonderful. And there's actually this hot debate in the palliative care field at large of like, how useful is it? Because people change their mind constantly. And I think that's great. It's not to say not to do advanced care planning, but also to know that it's ever evolving and an iterative process for people, because no one can predict that this would actually happen to them. And so sometimes it's just really helpful to frame, because I think sometimes I think it's for caregivers, they feel like the choice is on them. And I think a lot of times, when Scharukh and I are having these conversations and making sure they're aware that, hey, we're the experts, you're the expert on your loved one, your mom, your grandma. We value and we need to learn from you how she lived her life and the priorities and the things she would absolutely not want in her life when it came to sort of her quality of life. And then we can fill in the blanks about what makes sense and to make recommendations aligned with sort of what those priorities are. And that's, I think, best case scenario if it works out that way. A lot of times in real life, though, things are not as straightforward.
It's a little messy and gray.
Yes, very messy.
Yeah. So from my perspective, Jason, I think of these exactly what you presented in your first slide is, obviously, if we're not going to complete the treatment, we're already in the palliative bucket. And then we have this conversation and bring in our palliative and hospice care folks on board so we can have a collective discussion. From a surgical perspective, this lady obviously has many issues from a healing perspective. I mean, forget about dementia for a second. I mean, the methotrexate, the prednisone, the polymyalgia, we know it's going to be a bad outcome. Now, having said that, if someone's not going to get definitive treatment, we still have a role, I believe, if patients fit enough, to create a clean wound. That's what I say, a palliative procedure, because having older parents myself, I think dealing with a patient like this is a handful for the family. It's very hard. And so we talk about that we can make it cleaner. We can resect this, put a skin graft. And however long mom and dad are going to live for, or uncle, aunt, whatever, whoever they are, at least it might be less of a burden for the family to keep this clean. Because I'm pretty sure this wound is going to bleed every day. We were just talking about this yesterday in my clinic. It's going to get the sheets dirty every morning. Someone's got to clean it up multiple times just to get from a hygiene perspective. And then you can get skin infection and all that stuff. So at least we can do that, or at least offer it. The biggest thing, obviously, is the skin. Another point I just want to make here is I deal with very advanced head and neck cancers, throat, pharynx, larynx, so on and so forth, tongue, which have gone crazy. So, they're wrapped around the carotid. So for us, code status discussion is very critical, and we actually do it on the surgical service. I don't know if other surgical services do, but we do it. I have fellows who come in who find it very, very strange that we're talking about code status. But I've learned a lot through Kathleen's service, so we're very thankful to be partnering with them. So we are not scared of talking about code status, DNR, DNI, all that stuff. Because at the end of the day, if someone's going to come in with a carotid blowout, it's better to have that discussion while they had the capacity, or the family had a clear mind that, hey, because people forget, like this lady, let's assume she had a pharyngeal cancer wrapped around the carotid. She'll come in with bleeding. The family will forget about the fact that mom's got dementia and an incurable condition. And it happens to everyone, all of us, I think, when our loved one is coming to the end. So I think those discussions are very critical in our clinic, because I do see the older patient with very advanced, not only skin cancer disease, but upper digestive tract disease. And so that becomes important. But I think from a surgical perspective, we can still create a clean wound, even though it's palliative. So I wouldn't say that, no, I'm not going to offer anything, as long as they can pass Dr. Coleman's test. Dr. Coleman, what you said was amazing, by the way. If they can pass their test and we can do something small, I'm happy to do it, with the understanding it is palliative. So we set that stage up on that first visit, so there's no confusion, expectations are met, and we go from there. And dementia, obviously, for us, from again, I'm not the expert, but I deal with it on the floors with our teams. It's hard to manage post-op, and I agree with Dr. Hall as well that, you know, these patients can go into bad dementia. Now you're going from the hospital to rehab center to this and that. I've had patients with bad PTSD. I mean, we recently had a guy who was stuck in the hospital for nearly 2 months. I think Dr. Lee's service also helped manage him. So, you know, it's like nuts when these length of stays go crazy because of these things. So that's really my 2 cents here. Thank you.
I love it. And I love the fact that you talk about code status. I think that's something that we need to be more comfortable, I think, talking about these things. You know, I have seen, you know, just maybe we'll end this on one final point here. I have seen local disease in the head and neck get so bad that nobody wants to go near these patients. It smells, it bleeds, and then you're talking about, you know, neglect and elder abuse. And so there is something to be said for local control. So, you know, we talked about surgical, and I think maybe one last question for you, Lannis, is we talked about how, you know, 32 treatments, 5 days a week for 6 weeks is just really not tenable.
Right.
But what about like, you know, quad shot or something like a palliative radiation? If you've got a big fungating, bleeding, nasty wound, is like a quad shot palliative radiation going to be helpful? Can you do that with these patients with severe dementia? Like what are some options that we can give our listeners here that we can help that patient, even if we're not trying to cure them?
Right. So we have a few regimens, and I have to give it to our European colleagues for really moving the needle forward on these palliative regimens. You called it quad shot because that's what we kind of affectionately named it. It's the Spanos regimen, and if I can pull it up really quickly, I'll drop it in the chat. But it is essentially when we give 4 fractions over 2 days. So if you could imagine a Monday and Tuesday fraction, BID, so once in the morning, separated out by at least 6 hours, and then they get 3 weeks off. And then we give another 4 fractions. They get another 3 weeks off, and then we give another 4. You can do it while people are receiving palliative chemotherapy or not. We have studied it with concurrent chemotherapy or as a single modality treatment. And the improvement in palliative symptoms, which typically are either pain or bleeding, or difficulty with airway or airway compromise, is over 60%. And initially, you know, I think there was some hesitancy because we thought that 3-week split course was really not going to be helpful because it would give time for the tumor to repopulate. But we're really finding that we can get some, you know, durable local control in a palliative setting. And when I mean durable, like longer than 6 months. But there are now other regimens that are being championed, and one is giving 30 gray over 2 weeks. So that means 3 gray times 10, and then a 2-week break for recovery of any mucosal changes, and then following up with 25 gray in 2 weeks. So another split course regimen. And this isn't considered like solely palliative. This is for, you know, trying to get durable local control equivalent to what we would give in 70 gray over 7 weeks. And I think the concern about 70 gray over 35 fractions is that most of our elderly patients can't complete that program anyway. And so
Even if they don't have dementia.
so you end up having treatment interruptions, and it's better to go ahead and give them a break and have their mucosa recover and then give the rest of the fractionation. And is that equivalent? So those are some of the regimens being studied, but Spanos, the quad shot, really has saved us with regard to palliating patients.
That's wonderful. That's well, I really appreciate everybody. I have learned so much from this and have gotten a lot of wonderful ideas of things that I want to implement. So I want to thank our panelists, Dr. Hall, Dr. Coleman, Dr. Wiles, Dr. Lee, and Dr. Jalisi. Thank you so much for sharing your expertise with us. This is such an important topic, and I feel like these discussions really help move the needle at all of our institutions. So thank you.
Jason, there might be a question I think.
Is there a question? Okay.
Are
there any questions out there? I know we've got a little bit over, but I've enjoyed this. So
I think we have a good audience. Maybe they can talk about the experience as well.
Yeah. Any questions from the group? Those that are still on.
Dr. Lucenti, any thoughts?
Yes, I heard a lot of excellent discussion about tumors and treatments, but I'd like to have heard more about the patient attached to that tumor. How do you get inside the patient's mind, understand the patient's understanding, understand the patient's desires, understands the patient's limitations? Some years ago, we learned that the word obesity can be replaced by horizontally gifted, a kinder term. I think maybe the word elderly can be replaced by longitudinally gifted. How do you deal with that? And as a WashU graduate, I must say I'm very pleased to hear all this. And as an 80-year-old, I'm very happy to know that these things are waiting out there for me. Thank you very much.
Thank you. Any thoughts on that?
I would. I think that I've been very humbled by what I thought I understood by a conversation in a room. And I think some of our older patients may have a conventional relationship with their doctor where their doctor says, this is what we think you should do. And we're giving all of the options, and our patients may not be as vocal and willing to give some of their hesitancies, their fears, and their true thoughts about what we are recommending. I will say I found our social worker to be very helpful in that regard, as to having a separate consultation independent of me. And I've been humbled by them by coming back and hearing, well, they really don't want to do that. and when I was in the room, I thought I thought they wanted to do it. So I believe having family members, but sometimes family members just aren't accompanying our patients, and occasionally they're by themselves. And that's when I do believe, I wish we had a really strong palliative care team at all our satellites, and we don't. And so I've really relied on our social worker to help gauge this. That would just be what I would say but I've been very humbled by what I thought I heard in the room, in the wishes of the patient.
And I think what you were, oh, go ahead, Scharukh, go first.
Go ahead, do your thought.
What Lannis was saying, I think your social worker is doing really good palliative care, and I think really it's a matter, and I think part of it is, unfortunately, all the constraints and the competing sort of responsibilities and roles we have. I think sort of what Dr. Lucenti was saying, I think sort of how do we get to the person? It's sort of giving that space. And And it, you know, I feel privileged as a palliative care specialist. That's my job. And so I can do a half an hour follow-up and just explore, tell me more, what brings you joy. And it sort of, that sort of fills my well, you know. And I will also see, though, you know, I think you don't need a half an hour or an hour for initial visit. It's just a matter, you see sort of a twitch or sort of a worry on their face, and just say, I notice some hesitancy, you know. And I think some of the tools that I sort of, the links in, are just naming what you're seeing in the room. You seem worried, just to give them a little bit an opening to share. And maybe then, you know, Dr. Hall may not have time, you know, to sort of explore that. She might need to go to a patient, but then she can refer to the social worker or whoever else, you know, may be able to explore and have that skill set to learn a little bit more about who that person is, as you know, you were asking.
Well, thank you.
And in the surgical clinics, at least in my surgical clinics, I mean, the first third of that consultation is nothing to do with the cancer. We just want to know about the patient, what they do, what makes them tick. So referring to what you said, Dr. Lucenti, it is who's in your family, what do you like to do for fun, you know, what is it that you really want to do? And eventually we come to the conversation around cancer. But I think that initial stage, and it's very helpful for the trainees as well to learn these, because we learn a lot about our patients and what they've done. I mean, I deal with patients from everything, from people who are homeless to professors, you know, and it's kind of interesting the journey people have had, and where they are now as you say, longitudinally gifted patient. And everyone's desires change over the course of their lifetime. And so I think that's very important. And then we find out about the support structure, so on and so forth. We do not have a social worker in our program, but I think that would be a great addition. I'm going to go back to the hospital and ask for it. Dr. Hall, thanks for that. But that's what we do. I mean, the first part of the discussion is all about patient, not about cancer, but everything else, about patients' life journey, and learning from them about what their life is, what their support is, and so on and so forth.
Thank you. Any other thoughts? I think it comes down to time and listening, doesn't it? I think everybody's saying that. Just got to make time. And I found that, you know, for me, it almost takes more time to have one of these discussions. I don't have a social worker palliative in my clinic either, so I wish we had that. But for me, these discussions where you're really talking about palliative or hospice take longer than, you know, a younger patient with definitive, you know, a huge surgical resection. But I actually find them, like you said, Kathleen, very, very fulfilling on a deeper level, where you get to really connect with that patient and feel that you're providing good care and helping guide them in a good way, safe way. So,
yeah, and I thoroughly endorse that. I must say, listening is one of the most important things we do, but there's no CPT code for it. So plan, listen.
There's an advanced care planning code. I forget exactly which one it is. I use it all the time, but it does exist. Time-based.
Any other questions? I'm looking at the chat if we have any. I think we've got that. Any last comments from our panelists? No. Well, thank you again, Helga, Lannis, Scharukh, Tanya, Kathleen. It's been a pleasure. Thank you to ASGO. We're gonna collect all of the links and resources that have been put out there, and we're gonna make sure that we can have those on our website. And there's the CPT code as well. So we'll put all of this on the ASGO website. So thank you, and have a wonderful evening.
Thank
Thank
you.
you.
Thank
Bye-bye.
you.
Thank you.
Thank you
Bye-bye.
again.
Bye.